following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, tobacco. Two experts are here to answer your questions. Now here's your host, Dr. Raleigh Sullivan.
Good evening. As more public places in West Virginia restrict the use of tobacco, many smokers may be thinking it's time to quit. But for most people, that's easier said than done. Most people who try to quit have to try and try again before they're successful, if they ever are. And that's because nicotine is a drug more powerful than cocaine, and that's a tough addiction to beat. So what are the latest methods for quitting tobacco? Are prescription drugs and nicotine patches an option for you? Is smokeless tobacco any better for you than smoking? And how can we help young people quit? We'll get answers to those questions and more tonight from our two guests, Dr. Jerry Dino, a scientist and director of the Prevention Research Center at West Virginia University, and Dr. Dan Ellswick, a psychiatrist at WVU's Hospital's Chestnut Ridge Center and Mary Bab Randolph Cancer Center, who specializes in treating cancer patients. If you'd like to ask our guests a question, give us a call. Or if you've been successful at quitting, please share with us what worked for you. Our phone lines are open now. And actually, before we start, let me also say that this is an area of interest for me as a psychiatrist who treats nicotine addiction. So Dan, let's start with you. This nicotine addiction, that's a tough one.
Nicotine addiction is very tough. One of the reasons, especially when you smoke, which is probably the most common thing we see in clinical practice and around the state of West Virginia, is it gets into your lung and then your blood and then your brain so quickly. Anything that gets into your brain the way that nicotine can and have its effect rapidly reinforces its own use, meaning that when it's not in your system, you want it, and when it's in your system, you feel good, even though it's not really causing a euphoria or a high like cocaine or heroin. So it's a big problem with nicotine, especially when in the smoking form, because it just gets in the system so quickly.
Okay, well, we're going to come back and talk because I think people might be curious as about how nicotine, works on the brain, but I want to get Jerry in this. Jerry, for you, I know you work a lot with adolescents. Can you talk a little bit about that? What are the challenges of working with tobacco use in adolescents?
It's kind of interesting, Raleigh, because the challenges of working with teens is very similar to the challenge of working with adults. Very quickly after a teenager starts to smoke, he or she may become addicted to nicotine. And it's taken a while before people really were willing to deal with the fact that teens, like adults, get addicted. And sometimes teens smoke. A lot of the time we think, well, kids, they start smoking to be cooler because their friends do it. Well, a lot of the time, teens start to smoke to control their mood, either to feel up or to help them deal with anger or to help them deal with depression, so that they develop a psychological dependence on smoking because it helps them regulate their moods, and then they also develop nicotine addiction just like adults do. And so the challenges in working with kids become very, very similar to the challenge of working with adults.
One of the things I always thought was interesting is that, we think about cigarettes and nicotine and the problems that are associated with that, and we need to talk about that in a minute, but nicotine addiction, and the problems, the heart disease and the lungs disease, et cetera, but the problems really start way before that. I mean, when does the average person in the United States start smoking cigarettes?
It really depends a lot on what part of the United States you're talking about. There are some differences based on race, but in general, you're going to see the age of onset anywhere between 11 and 14 years old. But in some places, some of the teens that we've worked with, they started smoking at 7 or younger.
Yeah, well, that's kind of my point, because what most folks don't think about is that smoking, nicotine addiction, is really an adolescent disease. It's a disease of pediatrics, and then the people, live into adulthood, and they carry that disease on with them. But it really starts as an adolescent. So
Absolutely.
if you smoke, long enough, let's just talk about that now, so we can sort of get this out there. What kind of problems do you end up with?
Well, I think everyone's aware of the risk for lung cancer, especially in cardiovascular disease, and those are things that have been in the public consciousness since the 1960s and 70s, but to a great extent, there has been sort of a reduction in the amount of smoking nationally, but people tend to ignore things like erectile dysfunction and skin problems that people have, a lot of different problems that you have with just, wrinkly skin. That's something that people don't even think about. There's almost every system you can think of, there's an effect of nicotine. Nicotine is a very potent drug. It affects the way people's medicines are metabolized by the liver in a way that people don't even realize. So yeah, the biggies are the cancer, the biggies are the heart disease, but there's a lot more that we have to look at and make sure that people around the state are really being informed about.
Okay, well, let's get our first guest in. This is Bonnie from Belmont County, Ohio. Bonnie, welcome to Doctors on Call. You have a question for us?
Yes, I do. My son-in-law was a cigarette smoker. He finally broke the habit, but he started using Skoal. But he complains of his stomach hurting a lot, and I'm wondering if that has anything to do with the Skoal mixing with his saliva and swallowing, if that would hurt his stomach in any way.
Do one of you want to take that question, or do you want me to?
It certainly can be. I think maybe that would be one that would be right up your alley.
Let me just, with regards to smokeless tobacco and the nicotine that's in smokeless tobacco, it's true, if you have a lot of saliva and you get the nicotine in your saliva and you swallow it, it will hurt your stomach. And a lot of people will complain about that depending upon how much nicotine they actually swallow in their saliva. That was that was a problem with the nicotine gum, which was the first, and maybe we'll talk about that here in a minute, but the first treatment product that came out was the nicotine gum, and a lot of people would chew the nicotine gum and they'd get a lot of saliva that was mixed with the nicotine in the gum, and then they would swallow that and it hurt their stomach. That goes away really when you quit, you quit swallowing all this nicotine, but it is something, you bring up an excellent point. I think a lot of people really don't realize that. Yeah. Let's talk about some of the treatments available for smoking cessation. Who wants to start?
Let's start with adults.
Adults?
Start with adults.
Basically, broadly, you can think of treatment being behavioral or pharmacotherapy, which is basically nicotine replacement products or non-nicotine replacement products. We've had available either over the counter or by prescription a lot of nicotine replacement products for a good 20 years now. And one of the first things that came out, of course, were the patch, and a lot of people, there's a lot of stigma and mythology about the patch as to why it does and doesn't work for some people. And then the gum was available, which, if used correctly, can be a very good alternative for smoking because it kind of gives you that behavior. Likewise, there's the Nicotrol inhaler, a nicotine inhaler, which is helpful for some people, which carries all these carry a little bit of a burden of different side effect. Then we have a couple options as well by pill that don't use nicotine as the sort of primary source of therapy.
Do you want to mention what those are? We'll come back to it. Sure.
There's bupropion or Zyban, which is basically an antidepressant medicine that seems to work on the reward system, and then there's varenicline or Chantix, which also works on the reward system, but in a different way. Both of those medicines can work when used appropriately, when in conjunction with the primary care provider, and especially when you use the pharmacotherapy and counseling in a combination, you can really see good results.
Let me get our next caller, and this is Ruth from Putnam County. Ruth, welcome to the show. You have a question for us?
Yes, I do. My son and daughter-in-law, they quit smoking about 6-7 years ago, I'm guessing.
Yeah.
But they still use the lozenges, or nicotine lozenges. Are they habits of their health?
Well, that is a really, really good question. the truth is that they probably are doing better if they're using the nicotine lozenges and they're not smoking cigarettes. They're probably doing better. When you inhale tobacco through a cigarette, you get about 4,000 different chemicals down into your lungs, some of which cause cancer, some of which cause high blood pressure, some of which cause heart disease. When you use the nicotine lozenge or the nicotine patch or the nicotine gum or the inhaler or any of those products, the only thing you're really getting is nicotine. And nicotine by itself really doesn't cause a lot of physical problems that we talked about. But nicotine by itself is a very, very addicting drug. And so the people will stay on nicotine sometimes for a long time. That happens with the lozenge, that happens with the gum, that happens with a patch, happens with all the nicotine replacement therapies. And it probably is much better for them if they can't get off of nicotine that they're on the lozenge rather than still on the cigarettes. Okay? Do you want to talk about, I want to get back and talk about adolescent treatment. What would be different?
Well, what's the biggest difference between what you said, Dan, with adults and what's available for teens is that there's no product that's currently approved. There's no drug or pharmacological treatment that's approved for use with people under 18. So what we know right now is that the most effective treatment for teens is when they meet in a group in a fairly intensive program that's at least 6 weeks long, and that program would help them understand why they smoke, how to, what nicotine addiction is. We find that when teens really understand about nicotine and how it affects their body, it does seem to make a difference. There are a variety of other techniques. These programs will help teens to figure out how to manage their stress without cigarettes, how to get friends and family to support them in their quit attempts. Yeah. What's really important in these programs is that both the teens and the adults in our lives that also want them to quit to realize just how powerful an addiction nicotine is.
Yeah, well, obviously I want to talk some more about that. Everything you guys are saying is resonating with me. We have another caller. This is Bonnie from Allegheny County, Maryland. Welcome to the show, Bonnie. You have a question for us?
Well, I just wanted to tell you my success story.
Okay, good, a success story.
It's a success story. I smoked for about 40 years, pack and a half a day, sometimes 2 packs a day. And about 7-8 years ago, I quit by using the patch. Now, I didn't quit. I didn't follow it according to the directions because a 40-year habit, I didn't think that I could conquer in a couple, 4 or 6 weeks. So I wore the first patch for about 2 months. Then I went down to the second step, and I wore that for a couple of months. And at that point in time, then, changing a few habits, I have never smoked. In fact, I can't stand the smell of a cigarette anymore.
You know, Bonnie, you are to be congratulated. And actually, what you did is really a much better thing to do. A lot of people will try to use these products, but they don't use them long enough. They just use them for a few days or a couple of weeks, and then they're hopeful that their nicotine addiction is behind them. And as you said, if you've been smoking for 40 years, it just doesn't go away overnight. You have to make some serious changes. And so what you did, stepping down over a longer period of time, actually makes a lot of sense to me as an addictionologist. And I would recommend that most people who are going to use one of the products, that they try to use it in a more prolonged fashion like you're discussing. I think when people try the gum or the patch or the inhaler and they just use it for, a few days or a couple of weeks, oftentimes what you see is that you see people relapse. And the way you've done it seems to me to make a whole lot more sense, so I congratulate you on doing that. Let's talk about the non-nicotine replacement therapies. And let's go over them again. The nicotine replacement therapies are the gum, the patch, the inhaler, the nasal spray, which we haven't mentioned even, and the lozenge. But there are a couple of other medicines that are available that are not nicotine-based. Why don't you talk a little about those?
So the first medicine I'd like to talk about is Zyban. It's also called bupropion, and it's been out for several years and has really good efficacy for smokers. And when you think about going on any sort of replacement or non-nicotine replacement product, you have to look at things like level of dependence and things like that, you know, and really make sure that you're looking at risk versus benefit. But basically, the bupropion really helps work with the reward system. So what you would do is you would start it about 2 weeks before you have a quit date, and you'd use the medication and kind of treat the brain disease aspect of the addiction as best you can with that. And what it does, it really helps the nicotine not be as rewarding to the system when you do smoke or you do chew and do use nicotine. The other medicine that is available is called varenicline or Chantix, and it's pretty interesting in that it really kind of fools the system into thinking that the nicotine's there, but then if you try to smoke on top of it, you don't get the reward.
Right.
Very different kind of medicine, a very novel sort of treatment that we have, and something that's very exciting. Both of those products, when used appropriately with guidance from a primary care provider, and especially in combination with therapies such as, you know, some of the cognitive things we discussed, certainly can really help people's chances to remain smoke-free.
Yeah, absolutely. We have another caller. This is Tammy from Hampshire County. Tammy, welcome to the show. You have a question for us?
Yes.
Okay.
My question is, I tried the nicotine patch, and I'm still smoking, but I tried the CVS brand versus the nicotine brand. Is there a difference between the generic and the prescription?
There's really not much difference. Let me just say a word about that. The patches, if you're a fairly highly nicotine dependent smoker and have had a lot of trouble quitting, and if you put one patch on and you're still craving, one of the things we know now is that, and this is an off-label discussion, but a lot of doctors will do this, they'll put 2 patches on. And 2 patches is more likely to give you nicotine, is to control your nicotine withdrawal symptoms so that you're not craving cigarettes. We've even had people with three patches on when they get started, because some people are very, very highly nicotine dependent. The patches work great, but if you put 1 patch on and you're still really craving a cigarette, likely you're not getting quite enough nicotine from the patch. And the other part is, as we kind of were talking about earlier, is that you may need some, you know, to change some of the habits and the routines and the rituals around what you smoke. And people have to pay attention to those sorts of things.
Yeah, absolutely. The average pack-a-day smoker is getting about 40 milligrams of nicotine per day, and the starting dose of the patch is about 21. That's the CVS brand or the non-generic brand, and so you've got to kind of use that as a starting point. It's real important to see how much dependence people have when you're starting.
Let's talk about, well, let me say one other thing that we probably need to at this point. You know, I'm aware of the fact, I'm sure you all too, most people who quit smoking in the United States did it on their own. If you look back over the past 45 or 50 years, most people that quit on their own. And we're now down to, in the United States, about 20% of adults smoke cigarettes in the United States, roughly. But the people who are left smoking, it seems like, really are likely to be very highly dependent smokers. These are people who have tried and quit, and again, because everybody knows smoking is bad for you, right? Everybody knows. The kids know, everybody knows smoking is bad for you. But we're now left with sort of a group of smokers who just telling them to quit is probably not enough. So what would you, I'm just going to ask you both, what would you recommend for this group? Because it is getting to be a difficult group who's sort of left still smoking.
I could probably speak on adults, and then
Okay.
we can talk about adolescents and older adolescents. Well, I think you're right. There's, nicotine dependence is a hardcore brain disease. And yeah, you can say as much as you want about it being a social this or that, but it causes a big physiological change. And so I think approaching things from not only the chemicals that we can give someone or the replacement we give someone, but looking at the family and looking at really the benefits that you can have beyond just, okay, this is going to, because they know that cancer is a risk. And,
right.
Yeah, so looking at what is this going to do to your grandchild? Some of the more psychological and sort of family issues can really help too. And I think more than anything, this repetition. They've shown that less than 3-minute intervention by a nurse practitioner, a physician, a nurse, or in a school setting can have robust effects. So, we've got to do our end in the medical community too to say, this is a long-term disease management state where we have to do it over periods of time. It should be a vital sign, and a lot of places do treat it like a vital sign. And if you don't smoke, you keep reinforcing the reasons not to smoke, and if you do smoke, you assess what's keeping people smoking.
And keep trying to quit, and keep trying.
Sure.
If you're smoking, the important thing is you got to keep trying to quit. Jerry, why don't you talk about the NOT program a little bit?
The Not on Tobacco, or NOT, was a program that was developed here in West Virginia for West Virginia teens, and then while we were actually developing the program, the American Lung Association heard about it and they wanted to get on board, so now it's a national program. And it's a teen smoking cessation program. It helps teens to quit or to reduce smoking, but it also helps them to eat better, be more physically active, manage stress, and be more effective at working with at interacting with people. And one of the reasons is with teens, teens have this sense of independence. But interestingly, teens who smoke today, to get back to the issue you said about hardcore smokers, some people are thinking that that's the case with teens who smoke as well today. So the teens who continue to smoke are hardcore smokers. They're going to have a tough time. Most teens who smoke want to quit, but they can't quit on their own. So what they need to do, my recommendation would be that they find some kind of group or get online, try to get some sort of support beyond themselves. And one of the most important things is that if you're a parent and you have a teenager who smokes and you think that your teen wants to quit, be as supportive as you possibly can, because this is really, really tough for kids. And it can be harder for a teen to keep smoking when a parent smokes than it is for a parent to keep smoking than the other way around. Teens really, really, really need the support of their parents. They need the support of their teachers. They need the support of their older brothers and sisters, because they don't have the freedom and the independence that an adult does.
Yeah, that was really well said. I'm glad you brought that in. Let me get the next call. This is Marie. Marie, welcome to Doctors on Call. You have a question for us?
Yes, I do. I wonder why more women seem to be smoking now than men, and they smoke so much around their children, even little babies in carriages. You'll see them light up, in a stroll or something, you see them light up a cigarette and start smoking.
Well, actually, statistically, slightly more men than women smoke, but you do bring up a good point about women smokers. Who wants to talk about that?
The rate's been going down for men and women. That's the good news, at least in the United States. It's going up in the world, and that's sort of the tragedy in this. But really, I think it's tricky because while it's going down in both sexes, it's actually going down at a slightly slower rate in women, and I think that's the big issue. So
some people think that one of the reasons is that women who smoke tend to be more depressed and anxious than men who smoke. And so for women, smoking may be using smoking to control mood, particularly to not feel depressed or anxious, may be a very powerful motivator. And women will smoke, if a woman smokes around her children, it very well may be that she just doesn't realize, she may think, well, this is hurting me, but it's not hurting my children. People often don't realize that exposure to secondhand smoke can be almost as harmful as smoking yourself, especially the effects on the heart and the blood vessels. So that it's very, very important for those of us who do this kind of research, and for doctors and for people in schools and other members of society that have an influence, to let people know secondhand smoke, particularly around children, can be very, very harmful.
You're exactly right. I think for years, doctors, all of us underestimated how bad secondhand smoke is, and we've certainly come to understand that more as we go on. We have another caller. This is BK from Raleigh County. BK, welcome to the show. Do you have a question for us?
Yes, I do.
Okay.
I haven't smoked in 4 years, but I do use nicotine replacement gum. I'm addicted to it, most probably now. Do you have any suggestions for me? And also, the hazards of nicotine replacement gum, and if there's any link with thyroid disorder and the nicotine replacement gum?
Well, as to your last question, no, there's never been association with nicotine gum and thyroid disorder. Your question about being hooked on nicotine gum is interesting, and we sort of addressed it with a nicotine lozenge a little bit ago. In Europe, about 10% of the people who get on the nicotine gum end up stay on the nicotine gum really forever. And so what you're doing is probably way more healthy than staying on cigarettes, even though you can't get off the nicotine gum. It's unclear that staying on nicotine, even just pure nicotine, for a long period of time really does much physical damage. And I would rather have you on the gum than a cigarette. Now listen, we're almost done, so each of you get about 30 seconds to say something that the audience needs to know. So why don't you start, Dan?
Well, I would just say that to our last caller, actually, if you did want to sort of set that down, talk to your family care provider. You can come down slowly with the gum. You could also use something like the patch as an alternative to help step you down.
If you want to step down, right.
But really, if I could emphasize anything, is it's not just heart disease and cancer. There's so much more that it affects.
Okay, Jerry.
I think maybe the biggest message would be, if you smoke and you want to quit, and if you have kids who smoke and you think they may want to quit, try to do it as a family. We have a lot of available resources in West Virginia for people who want to quit. We have the Quit line, the Why Not Quit line. We have the Not on Tobacco program that's in schools.
That is excellent advice, and I wish we could talk some more about it. We've been talking about tobacco use with Dr. Jerry Dino and Dr. Daniel Ellswick. I want to thank both of you for being with us. If you'd like more information, talk to your family doctor or visit the website for West Virginia Tobacco Quit Line at whynotquit.com. For Doctors on Call, I'm Dr. Raleigh Sullivan. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.